Hi, Tabby. Someone having an argument in the background.
just while we're waiting, so the Diabetic Foot Conference in Australia is in November, and Matt and I are involved in it, but we're having quite a significant part of it. And I think Rooney's a bit, aware about Pacific Island issues, because a few years ago we tried to get Rooney and a bunch of people to come over to Brisbane for the conference, but it just turned into a bit of a saga to try and organise it. But now DFAT through the college are supporting the meeting, so I'll be in touch. I think we've just talked to the college the last couple of days, but we should actually have quite a big part of the meeting about the diabetic foot problems in the Pacific Islands. And I think what we're hoping to do is have a number of hubs in each country in the Pacific Islands, like the lecture theatre at NRH, etc., and then have kind of talk about what's going on in the Pacific Islands and potentially what we can do to help and how to address the problems. So I think that'd be quite exciting. And yeah, but I think it's early November, Matt, I think, as I recall.
Yeah, I think it's
8th or 9th or something like that of November, but we should be getting in touch with everybody pretty soon to try and talk about that. So it's for over a couple of days, but there'll be definitely half a day at least based on focusing on the Pacific Islands, because we all know what a problem it is for you guys, and we're not sure that we're doing a great job ourselves, let alone with all our resources. So it's just almost impossible for you guys, and it's such an epidemic. It's pretty scary. Anyway, that's kind of by the by. I was just waiting for more people to dial in, really. I thought I'd
sure kill some time. Rooney, we have Tabby, who is an English trained vascular surgeon, originally from, well, not originally, but had worked in Birmingham in the NHS and is now over with me at Liverpool Hospital in Sydney. And she's obviously just really interested in the DAISI projects and Solomon Islands and the diabetic foot issue that's there. Whilst we're killing time, can you just give her a very brief sort of history lesson of the unit that you're in, and sort of just maybe fill her in on some of the landscape of the foot problem issue, diabetic foot problem issues that you're having and that you see every day?
Thank you. I'm sure the Pacific have similar problems, and I'm sure Elvis will also can share experiences. But for us, diabetes has been increasing, exponentially over the last 20, 25 years. From the surgical ward with hardly any diabetic foot in the 90s to now about at least 60% of the surgical ward is diabetic foot infection. And so here we, all of us look after diabetic foot. We have 3 units in the surgical department, and we all look after diabetic foot. And it's basically, people present usually quite late. And so we basically just look after the foot, and there is not very good community care for these people with regards to prevention of infection. And some of them, or a lot of them, also have difficulty in access to regular medications and so on. And usually by the time they refer to us from the outer islands or clinics, usually we, usually they're quite sick and just need an amputation usually. And our sort of dressing materials and care and so on are pretty basic. We also do not have orthotics and prosthetics support as well at the moment. So, the issues are, from, prevention to, sort of care to rehabilitation and so on. So Motivation Australia, which is an organization I think based in Melbourne, I think, who's been helping to support us recently with online training for some of our nurses over a course of a couple of weeks, and they're also trying to help us with diabetic foot wound care protocol, which we are still, sort of studying and looking at, and how best we can incorporate into our system. So basically, it's a big problem. Diabetic foot. Our patients are in the ward for up to 35, 40 days sometimes before they get discharged. Yeah, thank you.
And how do you actually manage? So are you predominantly doing lower limb minor amputations or major amputations or debridements? How do you?
It's all of the above. We do debridements, below knee, trans metatarsal, above knee amputations. Yeah.
Yeah, and if you're left with a minor amputation, do you predominantly close them, or how do you dress them, or do they just get discharged when the wound's completely healed?
Yeah, so it depends. If we do an amputation and the wound looks healthy, and then we attempt to, then we close it. If it looks, you're not sure whether, then we leave it open and secondarily close it. So it depends. One of our biggest problem now is, sort of follow up after the amputation. So we don't have a prosthetic service at the moment. The workshop is broken down. Yeah, so.
Yeah, it sounds like a really big problem.
Yeah, it is. It is a really big problem.
I think you'd enjoy going over there, Tabby. As I said, Rooney showed me around for a couple of days. It was fascinating, and sort of the extent, you really want to get in there and just spend a bit more time, help. So what do you think we should do with the plan? It looks like there's quite a few on now, Gary.
Yeah, I think this is a multidisciplinary problem. So I think perhaps that's how we should look at it, from primary care to sort of foot ulcer prevention to controlling the blood sugar control and comorbidities, and acute care to rehabilitation process and so on. So, but for us, it's basically the acute care, and I think developing a dedicated team of perhaps nurses and doctors to look after diabetic foot infections would probably be ideal for us. Like at the moment, the nurses who look after the general nurses look after sort of everything else. The same with doctors. But I think having a focused team focusing on diabetic foot care would probably be of perhaps they could provide a more high quality service, I would think. So I think training and so having a food wound care guide, and getting the materials that are going to for dressing and so on. I think that's probably something we could look at.
I think we have about 10 participants now. Obviously, four being including us. Did we want to do the talk or just keep chatting? What do we think the best plan is for this evening?
Yeah, I agree, Matt. I think we should go ahead with the talk. You put a lot of effort into it. I'll just basically, we've got Ako Milan from Kiribati. We've got Mike Bouin from Gizo. Is that right, Mike? Western Province of Solomon Islands. Elvis Jafflet from SOPAS Hospital, although he's currently in Port Moresby because SOPAS has closed down due to some tribal conflict. Dominic Inado and Roger Ikasa from PNG, both senior registrars, and everyone knows Rooney.
So, Tabby, did you want to try and load up your PowerPoint?
Yeah, I've been having anxiety attacks about this all day. How do I do it?
How do you make a surgeon turn on a PowerPoint presentation? Huh?
Do I just press share screen?
Yeah, I think so.
Host disabled, participant screen sharing.
Oh, someone will just need to enable.
Gary will have to let you. Yeah. Sounds like one of those social worker jokes. How many social workers are paid to change the light on? Anyway.
Joke.
Yeah.
Can you see that?
Yes. Yep.
Looks good.
Wonderful. Yep. Wonderful. So I don't know if Matt, do you want to start? And
if you could just move, if you can move through, then that probably helps.
Yeah.
So yeah, just basically, as Rooney touched on, I think the predominant cause of admission for patients with diabetes and foot disease in the Solomon Islands was for foot infection. It's the primary driver, I think, no matter where you are around the globe in people with diabetes, as to why they require a lower extremity amputation. And so part of trying to manage the care of patients who present with foot infections is to try and have a standardized approach to your practice. And I think at some point, Rooney and Rob, we did touch on whether or not we were going to go through together at some point and work through these guidelines by the International Working Group for the Diabetic Foot. They're a collaboration of experts in infectious disease and surgery and podiatry and so forth that have come together and designed these guidelines. But we did discuss at one point whether we were going to try and go through them and see where they were applicable to the Solomon Islands, and obviously we never got round to that just because we couldn't attend with COVID. But if anyone does want to have a look at stuff, this is really a great resource. It's open access. You can just go on to the website and download it freely. If you just go to the next slide, Tabby. And basically that the guidelines have a few principles in managing patients, and it generally falls into these categories here. And so it basically guides you through, when to suspect a foot infection, how to assess the wound, the foot in the patient, when and whom to consult, when to hospitalize, how to collect certain specimens and so forth. But as obviously Rooney had alluded to, a lot of the patients present late, and maybe the majority of these really just sort of bypassed, and you're going straight into the more deeper end of hospitalization and surgery. But they are it's an interesting guidelines, and it does help you work through logically what you need to do for patients when they turn up. And so probably more so if we go to the next slide, Tabby, trying to integrate your clinicians that may be not in a national referral hospital, or maybe in an outpatient-based service, or wherever community setting that may be. These guidelines are really useful for helping them to determine maybe when to send patients to you, trying to determine maybe when patients can stay there and be managed locally, and when patients are obviously quite well and need to come in and have some surgery. So if we just go to the next slide. And so the real good thing I like about sort of infection is it's a clinical diagnosis and really doesn't rely heavily on diagnostics or any fancy machinery. You know, it's a lot of it's about clinician skill, using your hands, using your eyes to look, feel, touch, and smell, trying to ascertain the depths, or if you know something tracks or tunnels or moves deep to the deep compartments. A lot of the time, patients may have distinguishable features. You know, the foot's red hot and swollen, the toes exploded, and it just looks very unhappy. There's maybe a foul smell, the foot's very boggy, there's lots of swelling. And so, you know, the key thing with these guidelines is they don't talk about using lots of diagnostics, lots of tests. They talk about using clinical skills, which I think is even more pertinent to the setting that you and your staff are in, Rooney. Just to the next slide. I think
okay, thanks, Matt.
You now, yep.
Yep. So when I'm faced with any kind of foot wound, I tend to break it down really to three main contributory components. Infection, Matt's talked about a little bit, and we'll come back to it later on. But is one component, but another one is pressure. And I think neuropathy is a primary problem as to why pressure is an issue. And my next slide talks a little bit about the types of neuropathy and why patients with diabetes get it. And the third factor is ischemia. So if someone's got a wound that isn't healing, or a wound that isn't progressing quite as you would expect it to, you know, they've been in hospital, they're post-op, I break it down as it's one of these three things that is stopping a wound from healing. Now, infection can be your obvious abscess. It can be a wound that's pouring out pus, but sometimes it can be something a bit more subtle, such as a tiny little nidus of infected bone, a bit of osteomyelitic bone that's just driving a chronic inflammatory process. And ischemia is important because if a wound or a foot doesn't have enough blood going into it, then no wound is going to heal. But if we move on to why pressure and neuropathy in particular are a problem, well, when we think of neuropathy in medical school, we all sort of learned about glove and stocking neuropathy and diabetics. Well, yes, that's important, but why does sensory neuropathy cause patients to develop foot ulcers? It's because they lose their protective sensation. So they aren't aware that they are walking on hot wooden floors or on hot tarmac, or they've got a foreign body embedded in their foot. They can't tell if their shoes or sandals are pinching on their feet. And all of this leads to micro trauma and constant abrasion to quite vulnerable skin. And their skin is vulnerable because they have autonomic neuropathy that goes hand in hand with the sensory component. And so these patients have very characteristic dry, fissured, cracked skin, particularly around their heels. And they also have, on a cellular level, altered blood flow regulation. So their skin just isn't getting the oxygen and the nutrients it needs to remain healthy. And thirdly, they have motor neuropathy. So again, as the pictures at the bottom showed, these patients have very characteristic kind of clawed feet with abnormal pressure points, particularly on their metatarsal heads and on the tips of their toes. And that's due to wasting of their intrinsic muscles, changed biomechanics, and all of that leads to sort of muscle imbalance, changes in their foot architecture. Now, the autonomic and motor neuropathy are quite visual things. You can kind of see that somebody's got that, but sensory neuropathy is a little bit more subtle. And I can't remember the last time I saw a tuning fork in any clinic I've been to, let alone a Siemens-Weinstein monofilament. And so sensory neuropathy, you can't trust these patients to tell you that they're neuropathic, that they can't feel their feet. They often don't know that they can't feel their feet. But there is a screening tool called the Ipswich Touch Test. I'll just play the video at the bottom to see if hopefully it will play. And all you need to see whether or not someone's got sensory neuropathy is a finger and a foot. And you ask the patient to close their eyes, and then for a second or two, you rest your finger firstly on their big toe, then their little toe on one foot, then their big toe and their little toe on the other foot, and then the middle toe on either foot. And you ask the patient to tell you when they can feel you touch them. And if they fail to correctly label 2 of the 6 points that you've touched, then they are by definition neuropathic. They have sensory neuropathy. This again makes their feet very, very vulnerable. If we move on to ischemia, well, pulses, examining for pulses as part of your clinical assessment, I think is very important, because the absence of pulses is indicative of arterial disease. Their presence doesn't exclude it, but if someone's got a pulse in their foot, anything you do to that foot is probably going to be good enough. The blood supply is probably going to be good enough for the foot to go on to heal. To feel for the posterior pulses that you can feel in the foot, one is the posterior tibial, which is at an imaginary line drawn just between the malleolus and the Achilles tendon, and you can usually feel a pulse there. And the second pulse that you can feel is the dorsalis pedis, which is just lateral to the extensor hallucis longus tendon. Now, if you can't feel pulses, there are other ways that you can assess somebody's circulation. There's a test called the Berger's test, which gives you a vascular angle, and you can see that in the top picture there. So in health, elevating somebody's leg even to 90 degrees shouldn't cause pallor in their foot. If, however, their blood supply is compromised, raising the leg even for as little as 30 or 60 seconds will cause the foot to go white. And the angle at which this happens can be recorded. Lowering the leg then causes reactive hyperemia or sunset foot, as the arterioles within the foot dilate to get rid of the toxic metabolites that have built up during the period of ischemia. So that's another good way to assess whether or not somebody's circulation is good enough for a foot wound to heal. You can also quantify the circulation further by getting an absolute pressure of the lower limb circulation. And all this requires is a stethoscope and a blood pressure cuff. And you ask the patient to lie supine, you place the cuff above their ankle, and you place the stethoscope over the arterial signal points, which are the DP and PT pulse points that I've just mentioned. And there's also the perineal artery, which is the third artery within the calf that naturally peters out about 10 centimeters above the ankle joint and gives off 2 anatomical collaterals, which then go on to supply the pedal arch of the foot. And if you place a stethoscope over those 3 points to auscultate the perineal artery, you place the stethoscope cuff about 10 centimeters above the ankle joint laterally behind the bone. You inflate the cuff until the signal disappears, and then release it. And the systolic blood pressure recording that you get is when the sound returns. And if the absolute systolic reading of somebody's blood vessels within their calf is less than 70 millimeters of mercury, then you know that their foot wound is not going to heal. And this is important because if a foot wound doesn't have enough blood getting into it, then it might be worth considering a higher level of surgical procedures. So, for example, you might actually just be prolonging a patient's morbidity by carrying on debriding a foot or taking or nibbling bits more, further toes off. Actually, what might be needed is a major level amputation, so a below knee, a through knee, or an above knee amputation. And Matt, I'll hand back to you.
We're jumping back into the infection phase now, aren't we? So you've sort of sat there with your patient, you've trying to understand a little bit of background about the history, presence of peripheral neuropathy, and in particular presence of peripheral arterial disease, because as you've rightly said, that may take you down a slightly different path as to what you consider to be a surgical approach. You've talked about whether you're going to remain more local or you are going to do something more major. And so I suppose if you have a patient that comes and presents to you with this sort of picture that you've got here, which is probably pretty common, from my perspective, some of the first things that I start to think about is what sort of structures are involved in the foot. And so I'm just dealing with an infection that's just in the skin or soft tissue. Am I dealing with an infection that maybe is just in the bone, or am I dealing with both and something that has both a bony pathology and a complex skin and soft tissue? And again, I start to try to find a few more details with regards to the presentation that may make me decide for and against sort of admission or requirement for a surgical intervention. And I think obviously in your setting, guys, this again is probably more amenable to patients who are presenting to an outpatient service. And as you quite rightly said, Rooney, many of your patients are already way past this line and demonstrating many of these features potentially for systemic inflammatory response syndrome, or even sepsis, septicemia, septic shock. So these are again all fitted within part of the IWGDF documents, which we talked about. So I think this is a really important concept and might actually come a little bit more into the end when we maybe have a little bit of a discussion. But if we look at managing foot infections from an infectious disease process, goals of managing that infection is to understand the infection you're dealing with. So is this a chronic infective pathology, maybe with something which is more slow growth in terms of an acute rapid onset? You know, understanding, therefore, if that patient needs to come in and have something immediately, if there is gas in the tissues, or if there's any necrotizing fasciitis, or whether the person can hang on for a little while you figure out what your approach you want to take. You want to understand how best to eradicate or control the source of the infection, and obviously making some sort of decision that is based on some sort of evidence. But the key here really is around what we call source control, or control of the source. And so many of the patients that I saw on the ward, for example, had significant debridements and amputations. And whether you thought about it in the start of it or not, is the whole reason for you doing maybe some of those surgical approaches is to look at how you control that source of the infection. And in infectious disease practice, source control refers to all the physical measures used to control a focus or nidus of an invasive infection, and importantly, to restore the optimal function to the affected area. Now, that's an important concept which we'll touch on maybe at the end. So if we apply the same principle to foot infections, and the nidus or source of the infection is either the wound tissue and or bone, or both. And therefore, source control is the physical removal of all of the infected tissue or bone, and removal enough to augment the host immune response and the antibiotic therapy in gaining adequate pathogen clearance. And I suppose this concept really for me comes into play when we see maybe some of the patients that are on the ward with unusual types of amputations or debridements. And I suppose it's the consideration which we have with regards to the infection you're dealing with, on how much of that infection do you attempt or try to remove versus still trying to ensure that what you're left with is some sort of functional foot. And I think sometimes those lines become quite blurry, and we end up with very unusual amputations that significantly alter the foot architecture and leave patients with a foot which really probably isn't that functional anymore, and may mean often that that person ends up coming back anyway because they develop another problem down the line because of the foot that they've been left with. And I think that's a really important concept to consider, offsetting, you know, what you need to gain adequate source control versus what do you leave the patient with in terms of function and ambulation later on. And I think maybe that's just a brief chat if we have enough time when we finish. What's the next slide? This is you now, Tabby.
Oh, thanks. So we're just going to spend a little bit of time taking on board some of the anatomical considerations when you're dealing with diabetic foot, particularly infected feet. I won't go into it in too much detail, but if you look at the foot from the plantar surface, there are a couple of very important that we go through. So of course there's a skin, And then there's this plantar fascia, which you can see in the diagram on the right, which is a very obvious layer, and it's a fascial layer that kind of fuses down towards the calcaneal tuberosity. Underneath this lie the neurovascular structures. So you've got branches of the posterior tibial artery coming round and posterior tibial nerve, and they give off their divisions, and then these divide into the medial and lateral plantar arteries and nerves. And underneath that layer, you then have 4 layers of muscles. And I think there are about 20 muscles. And there are far too many for any of us to remember their names and all of their functions individually. So the way I break it down is that I then look at the foot as having 4 compartments. So there's a medial compartment, which essentially contains all the intrinsic muscles of the hallux. There's then a central compartment, which contains all the intrinsic muscles of the 2nd to 4th toes, and a lateral compartment, which is all the intrinsic muscles of the 5th toe. And then above that, you have the interosseous compartment, which, as the name suggests, contains all the interosseous muscles. And that's sort of how I break the structure of the foot down. And that's important for when you are making your incisions and where you think any infection may be tracking to. Over the last few weeks, I've taken some photos of our standard setups when performing various types of foot surgery. But for me, there are some key instruments. Now, they all have different names, but essentially, when I'm dealing with digital work or digital amputations, I tend to use a 15 blade, and I use a larger 10 blade for larger incisions. As part of a basic setup, you need some form of tissue forceps, be those Gillies, Adsons or Bonnies, you know, toothed forceps of some type. Langenbach retractors or skin hooks, just to give you better access. Halstead mosquito forceps, artery clips, whatever you want to call them. You can never have too many of those. Rongers or bone cutters, some kind of curetting instrument, so be that a Volton spoon. And then you get to more sort of diabetic foot minor amputation, major amputation specific kit, which includes periosteal elevators, and they've got a variety of names: Lempert, Wards, raspers, bone nibblers, and some type of scissor, and be that a Mayo or a Metzenbaum. Whenever you're doing foot surgery, particularly infected foot surgery, you need Fraser suction, you need lots and lots of saline, and you need gauze. And this is our very typical setup for skin and soft tissue debridements. This includes, if you go from left to right, you've got scalpel, then jump along and you've got some scissors, you've got some Gillies forceps there, and you've got an artery clip or a mosquito forcep. And in the background, you can see some saline or some gauze. And this is our standard setup for small or minor foot surgery. For more extensive skin and soft tissue, you've got your scissors, got a selection of toothed and non-toothed forceps, got a selection of artery clips of various sizes. Along the back row there, you can see some Zerny retractors, which have got the hook, and there's some Alice Saw, I think those are Littlewood's tissue retractors, and then also some Langenbachs. And in the background, you've also got a needle holder and some suction. Just to go through the instruments in a bit more detail, these are some typical retractors and some tissue forceps that I use to hold tissue out of the way so that I can get into a wound. So from left to right, there's a Langenbach, then there's a Zerny, then there's an Alice, and then finally a Littlewood's tissue forceps. For bony amputations, we've got a bone nibbler there on the left, and then bone cutters, and these can come in various sizes and they can be straight or angled. This is our standard major amputation setup. So it's all the kit that we've already talked about, but then in the bottom right, that big shield type thing is a Percy or a Sklar Percy or a Blake, whatever you want to call it, retractor. And that's used in below and above knee amputations to protect the soft tissue. You fasten it around the bone fits through the hole in the middle, and then your assistant can pull on the arms on either side. They can pull the soft tissue out of your field so that you can then attack the bone with whatever saw without causing damage to the soft tissues surrounding it. And these are the types of saws. If you don't have, I tend to use an oscillating saw, simply because in the unit where I'm currently working, that's freely and readily available. But traditionally there are subtly bone saws or a jiggly saw. I find jiggly saws can be a little bit cumbersome, and I probably don't use them as well as I should. I find that they get stuck. So in preference, I use a Satterley if I don't have an oscillating saw to hand. Then there's a periosteal elevator, the small thing that you can see in the tray, and a rasper as well. So let's talk a little bit about some operative techniques. You've got a couple of options ahead of you. If you're dealing with something that's just quite superficial, well, then a local debridement may be sufficient. If there's more complex, deeper structure involvement, well, that can require an incision and drainage. It can require deep tissue debridement. And the type of incision that I'll talk about in more detail a few slides down, the typical incision that I use with diabetic foot infections is a Loeffler-Ballard incision, which is a beautiful incision through which you can access actually all the deep compartments of the foot through one cut. If there's bony involvement, then obviously there's some local bone resection required, or sometimes a digital amputation. When I'm doing digital amputations, I tend to use skin sparing incisions. So I don't always perform a ray amputation. I tend to leave any skin that is healthy behind, just because it helps with faster wound healing. That said, though, I ideally try not to leave what this picture is showing, which is an undermined cavity. So you've got this healthy skin that one of my colleagues has left behind, but you get the impression that underneath that is quite a deep cavity that is heading up towards that toenail, and that then becomes a wound that's quite difficult to heal by secondary intention, and that cavity then acts as a bacterial reservoir. So I tend to make, although I tend to do skin sparing incisions, I think there's a balance which is quite difficult to impart of taking enough skin that you've got a broad-based wound that is easy to dress, that isn't going to collect bacteria and exudate and pus, versus leaving enough skin behind that they're going to progress to early healing faster. When it comes to operative principles, it's broken down, as with any operation, into the procedure itself, lavage, and then considerations for closure. When it comes to the procedure, I tend to have a very stepwise approach. It's my personal preference not to use a tourniquet. And the reason for that is that if you apply a tourniquet, everything looks ischemic, and tissue that may actually be healthy starts to look a bit grey and a bit blue and a bit unhappy. And quite often, you end up taking more tissue than you need to if you've used a tourniquet. And also, I tend to think that, well, there's probably not going to be that much bleeding from a digital artery that I can't control either with a suture or simply with pressure. So I don't tend to use tourniquets. It's important that you take all obviously non-viable tissue, regardless of the quantity. Sometimes it can feel like, oh my goodness, I'm just hacking away at this, but it's important that the first operation is the best operation. And so regardless of how much you are taking, anything that is non-viable just needs to go. It's important to actively look for tracts. I tend to use my mosquito forceps or my artery clip for that. And I tend to probe the tissue in various planes, because if the tissue separates very easily, that may be a tract through which pus or bacteria are tracking up the foot. I remove all tendons, all exposed tendons, high and under tension, having first explored and laid open their tendon sheath, because again, that's a very obvious source for tracking pus. So I lay tendon sheaths open and I take the tendons as high as I can. I don't tend to leave tendons exposed, and I remove any exposed bone that is obviously apparent in front of me. That said, I don't go looking for bone, but if it's there and it's staring you in the face, then I take it away. Lavage is by far the least exciting part of any operation, but it is arguably, once all the necrotic tissue is in the bin, the most important. One of the adages I was taught when I did general surgery is dilution is a solution to pollution, and it's true. You may get rid of all the macroscopic infection. You may drain all the obvious pus, but it's by diluting the bacterial load that is left that you can address the microscopic bugs that are left behind. And you often need litres of saline, and this can be time consuming. One of the ways that I set it up is that I have a nurse hold a large bag of saline over the foot, and I have a bucket placed underneath, and I simply ask them to squeeze, and I just pour saline onto the wound and just dilute all the bacterial load. I only close wounds when I am pretty sure that all infected tissue, and I'm confident that all infected tissue has been taken away. And often that decision can't be made in the first sitting. They often need multiple debridements or returns to theatre and multiple lavages before I would consider closing a wound. If given the choice, my preference is to leave a wound open and to then let it heal by secondary intention. As shown in the picture below, I sometimes do put in loose sutures just to oppose any skin flaps which can retract easily. And if I'm placing those, then I tend to use a monofilament non-absorbable stitch such as nylon or Prolene. I think this is one of the keys, and I try and impart it on all of our registrars, that don't be afraid of doing a necessary but arguably limited initial procedure. Get them out of trouble, drain all the pus, get their blood pressure down, their heart rate down, take everything that is obvious, and then take them back at 24 or 48 hours for a relook, because you then have a clearer idea of what needs to go and what can stay behind. If you're too aggressive in your first operation, then you can often take quite healthy tissue that could have been left behind with you, and that then leaves them with a greater deformity within their foot. These are some of the procedures that we've performed in the last couple of weeks and months. So this is a local debridement. This was actually performed just in our clinic. The patient didn't come to theatre. They had a superficial skin infection. You can see that there on the left in March, and we debrided it just with a curette in clinic, and by May we've gotten it to heal, as you can see on the right. This was an interesting case. This was a guy who had had some kind of insect bite whilst out in the garden, and you can see the top left. His foot, when he came in, it looked very dramatic, and we were convinced that, oh, this is going to be horrendous and he may well end up losing his foot, and we counselled him for it and all of that sort of stuff. But we took him to theatre, and the picture on the right there, you can see that that fascial layer, that aponeurosis that I mentioned earlier. And actually it was relatively superficial. So we took all of that dead skin away, laid the cavity open, and then a week later, as you can see on the bottom left, it had turned into a very manageable wound that, again, we let it heal by secondary intention. So very dramatic things can often turn out to be, with good debridement, with good lavage, can turn out to be far more manageable wounds, which will heal faster. I often get asked about exposed tendons. For me, exposed tendons have lost, you know, if you can see it, they've lost their tendon sheath. So essentially they're no longer functional. So I take them. Additionally, they're avascular, and scar tissue struggles to form over them. And in fact, if and when it does form, it will make the tendons more adherent. So again, their functionality is lost. So it's best to just snip them away. And if you're faced with a wound like this can actually be done on the ward. They feel no pain. You can just snip back as far under the skin margin as you can, and it leaves again a wound that is far more likely to granulate over and heal up. So I mentioned the Loeffler-Ballard incision earlier. So this is a recognised incision. It's described in the literature. That is a single incision through which you can access all the compartments, all the deep compartments of the foot. The incision starts between the head of the metatarsals, and it extends proximally towards and then curves up behind the medial malleolus. And this follows the natural anatomy of the flexor tendons and the soft tissue. So next time you do a diabetic foot incision, if you have a look, you'll see that all the tissues are sort of fusing towards that calcaneum, and that's what the Loeffler-Ballard incision follows. Furthermore, if someone's got aggressive infection tracking up into their calf, you can actually take this incision and you can follow it up into the calf and lay the calf open by taking this behind the medial malleolus. If you look at that picture of with the ulcer on it, again, with the eye of faith, you can kind of see that that a Loeffler-Ballard incision, which can start between any of the metatarsal heads, if you followed that down, it's kind of arcing towards that medial malleolus. This was performed by one of my colleagues. This was a Loeffler-Ballard incision. The patient obviously needed to have their toe off, and a drain was left in place. Now you can see that that drain, which is coming out a couple of centimetres distal to the most proximal margin of the incision, then leaves this cavity that's quite hard to heal. I mean, can't leave the drain in forever. I tend not to leave drains in my wounds by preference unless I absolutely have to. So what we did is we took the patient back and we just laid that open, because it turns a foot wound that is going to be challenging and difficult to heal into something that's just a bit more manageable. You've sprayed it open, all the tissue is there in front of you. When it comes to digital amputations, if we're talking about amputations that are limited to just a distal middle phalanx, I tend to perform skin-sparing circumferential incisions, which you can actually see in the bottom right-hand side of the screen. And I deepen the incision through to the joint space, the most proximal joint space. And the joint space should be proximal to the incision. So my skin margins, you've got a cavity under at the bottom of which is a joint space. I then disarticulate the joint and I nibble the cartilage head off just proximal of the proximal phalangeal bone. And when I say nibble the proximal head, all I'm doing with a bone nibbler or rongers, whatever you've got to hand, is just to remove the cartilaginous head of the bone. You don't have to take the proximal bone down to the middle of its shaft. Just nibble the cartilage off, and that will then allow a wound to heal over, because again, cartilage is avascular and a wound will struggle to heal over that. If you need to perform an amputation where excision or extension to the metatarsal head is required, but you don't necessarily need to take the metatarsal head, then I perform a racket incision, which is sort of named, I suppose, after a tennis racket, which is circumferential and skin sparing around the actual digit itself, and then a vertical slit which extends over the metatarsal head, and that gives you nice access down to the base of the toe. And again, you can close the skin, any skin flaps with monofilament sutures if needed, just to stop the skin edges from retracting and leaving a more gaping wound. If there's more extensive infection, then array amputation is sometimes what's needed. So you can see there in the top left, now that's quite a nasty toe. It involves the metatarsal head. The metatarsal head is going to have to go. And the incision encompasses skin sparing, so take all of the skin that isn't healthy, and take all of the dead tissue underneath, and then deepen your incision down to the bone. Remove all infected tendons and fascia, and again take the tendons high and under tension and explore the tendinous tract to make sure that there's no pus tracking down towards the calcaneum, which then may require something like a Loeffler-Ballard incision just to lay that cavity open. The bone is disarticulated at its proximal joint space, and then if you need to excise the metatarsal head itself and not just nibble it back, then I transect the bone along its shaft. And again, I tend to use some skin sutures just to oppose any obvious skin edges that will otherwise retract and leave a wider wound that will take longer and will be more challenging to heal. If somebody requires multiple digital amputations, I think it's probably best to try and avoid the situation on the right, sorry, it's labelled as left, on the right-hand side of the screen where you've got these skin bridges for adjacent amputations, because in part you're like, oh, I must save all healthy skin, but leaving skin bridges like that is leaving a wound that's quite challenging to heal. Again, how are you going to manage that space underneath? And a better option may be, as is shown on the left, to fashion a plantar skin flap and then bring that forward for partial or complete coverage. Just some pearls of caution or wisdom, whatever you want to call them. You've got to be mindful of the adjacent toe's blood supply when doing a digital amputation. Up until the midfoot, there's reasonable cross supply between all of the branches, but these then give off terminal metatarsal branches, and the blood supply to each toe sort of comes up along the side. And if you stray too lateral with your incision or debridement, you will inevitably render the adjacent toe ischemic. So you often find that you go in and you do a lovely amputation, and then a few days later, the toe next to it becomes ischemic and dies back. And that's because you've just got to be mindful of the terminal digital arteries as they come off the midfoot, and not to stray into those. When resecting the bone, I tend to bevel the edges, so I try not to leave a hard edge. So, for example, the diagram along the top is if you're looking at the foot end on in cross section. So if I'm taking off the hallux or the fifth toe, I tend to bevel the edges, and I can do that first by cutting the bone and then using a rasper. I think a rasper is a really essential piece of kit, particularly in digital amputations, just to rasp those edges smooth. And again, if I'm taking one of the middle digits, if you look at it side on, I again bevel the edges and I try and rasp it smooth. And I try to have in my mind that this bone that I'm leaving behind, if I was a patient and I'm going to be putting, I don't know, 70 kilos every time I take a step on this foot, is this bone going to be a source of future pressure? Or am I making the edges nice and soft and smooth so that that pressure problem is alleviated? If you do send cultures from theatres, it'll be interesting to talk about what facilities there are and how regularly you do send microbiology MCNS samples. Well, I think samples when possible are useful because it helps guide and tailor your antibiotic regime. But if you're sending them, then you need to be in a sterile environment, or at least an aseptic environment. I send dirty distal bone tissue or pus samples for culture. I then perform a thorough washout of the wound with at least 1 litre of saline, and then using sterile nibblers or forceps, I then take a little chip of proximal clean bone or a little bone scrape and send that off to the lab. Because if you'd expect the dirty distal bone to be infected because that's why you're performing the surgery in the first place. But the key is the tissue that you've left behind, i.e. the sample that you're taking with your sterile instruments, if that is infected, then the patient probably needs longer term antibiotics. And this process of sending your proximal sample, the sterility of the instruments, making sure it's done after you've performed a wash. I actually wear 2 pairs of gloves, and when it comes to sending the sterile sample, I make sure that I'm using clean gloves to handle the sample. I make sure the scrub nurse isn't using instruments that have been dipped in the pus and the mucky tissue beforehand, and I ensure that the labelling is correct. And if proximal bone chips are positive, then the guidelines say that you should treat with a 2 to 4 to up to 6 week course of appropriate antibiotics. I'll be really interested to hear your thoughts on dressings. I mean, there are so many dressings out there, and to be honest, if you've dealt with the pressure, you've dealt with the infection, and you've dealt with or assessed any underlying arterial disease, and you've done performed a procedure where the blood supply is good enough in theory for it to heal, then to be honest, in my eyes, you can dress a wound with anything and it will heal because you've dealt with the actual underlying problem. So back in 1956, Scales produced this list of the characteristics of an ideal wound dressing, but in some ways it's whatever you've got, and no single dressing is going to address all types of wounds in all their various stages of healing. So for me, the dressing part, yes, it's important. It's important to have a dressing that is changed at regular intervals. It's keeps the wound clean, allows it to breathe, is comfortable to wear, and fits in with your cost effect, your budget. But really, what you're using is neither here nor there. Saline soaked gauze versus high-end hydrocolloid gels, much of a muchness, really, if you've dealt with the underlying problem. So moving forwards, I think the way any diabetic foot service sort of starts, and certainly the way that I've managed my own diabetic foot practice, is that I keep personal and hospital-based auditable records, and because you've got to figure out what works for you and what works for your patient population. So within these records, I record the kind of basic demographics, record their blood supply. Do they have pulses, yes or no? If no, what was their Berger's angle? What was their absolute pressure in the foot? If I have the capacity to send cultures, and I make a record of any cultures that we grew, any treatment regimes we used. So what kind of surgery did I perform? Did they have to go back for theatre? And then what their ultimate outcome was. So did I ultimately save the limb? And if I did, what was the time to heal? Because there's no point in doing, in trying to save a foot, which, as Matt said earlier, is essentially going to take months, the best part of a year to heal up, and is ultimately going to leave them with a non-functional, biomechanically so unstable foot that they're just going to bounce back in 2 months' time with another problem. And I'd encourage everyone to share their results, so people can get very precious about, this is my data, but actually the way we learn is that we share our outcomes with each other, and we know, well, okay, I know somebody in Melbourne who tries this, who doesn't use the Loeffler Ballard, uses this incision, and actually his outcomes are X, Y, and Z. And it's by sharing information that we improve our practice. And I'll hand back to you now, Matt.
Oh, thanks, Tabby. That was excellent. I'm not sure what we put on the end. I'm very cognizant of time now that we're over. I think Rooney had touched on this anyway, that after the surgery, what happens with patients, and obviously having the difficulties with the mobility and trying to get the pressure offloaded. But as he touched on, there are some projects in place, such as Motivation Australia, who are trying to help, address some of the gaps in the provision of these sorts of stuff to patients. What was the next slide? Was that it, or was there one more slide? I think we'll probably just skip through this, Tabby. But there are many different forms that that we can have: total contact casts and offloading cam boots and walkers, and crutches. I think we actually touched on that the most basic concepts of offloading could just be crutches and or a wheelchair, in the absence of having these very expensive offloading boots that, even for us in Australia, would cost us. Well, for a cheap cam walker would be $30 to $50, and for the expensive ones would be anywhere from $200 to $400, and even we struggle with meeting that as a provision of care. So again, cognizant of time, Gary, are we good to wrap up, or are we going to have a few questions? How did you want to do it, considering we've gone a little bit over now? Are you still there, Gary? Is he there? Let me have a look. Let's see if I can see him.
I'm going to unmute myself. Yeah, I think 5 minutes for questions, particularly Rob, who's been very quiet, Rooney. So just quickly, we've got we've had a pretty good attendance, actually. We've had Roger Icasa, Dominic Inato from Alotau Hospital in PNG, Ako Milan from Kiribati, Nilani and Samuel Kemuel from Vanuatu, and Elvis Jafflet from Port Moresby, and Peter Hewitt from a place called Adelaide. He's probably cooking dinner at the moment because I haven't seen his face yet. There he is. But I think, yeah, any questions? I thought that was a fantastic talk. I like the to and fro between Matthew and Tabby. You've clearly rehearsed this talk and worked together well as a team, and I like it. It's good.
Yeah, I think we'll probably just, if there's anyone on who's joined in wants to ask anything that Tabby's touched on. If not, I suppose I could probably just comment on one of the things that are raised. But does anyone have anything for Tabby, or is that pretty much how practice is now with themselves? I would take it silence probably means yes. Okay, well, I'll put one out to Rob because I did think of a backup question, and I touched on it, Rob, and I think maybe sometimes it's an area which doesn't get too much thought because, you know, when a patient comes in and they're quite unwell, and as Tabby had touched on with regards to trying to get source control and trying to remove all of the infected tissue and everything that's around there. Is there a point at which you would consider before you go in for that about how much you need to take to sort of control that infection versus how much you think you might need to leave to ensure that the person's actually left with some sort of functional foot? You know, and I've seen it even here in our hospitals where patients come out with really, really unusual amputations, and you know, you sit there and you go, okay, this guy's going to have another problem because that's really not a functional foot. How do you balance that? What's the thought process behind it?
Yeah, I guess one of the big problems is that it can be quite hard to tell where the pus is tracking and how much necrosis is present. So it can be quite deceptive, and you can get a bit of a nasty surprise sometimes. And I think everyone's had that situation. I think if you think it's probably tracking to the ankle or, you know, proximal to the ankle, and you think they may need a major amputation, it's worth talking to them first. But a lot of patients don't accept that, and you just debride it. But then you end up sometimes with a dysfunctional foot, and, you know, then you've got the problem of, do you leave it as it is, and knowing that it's not going to be, you know, it's going to get into trouble and not really heal very well, or whether they'll agree to an amputation, you know, in the not too distant future. But it can be difficult. But I guess, I mean, when you're planning your incision and your drainage, you're kind of trying to work out if they're going to be able to walk on it. And it's, a lot of it's just experience, I suppose. But, you know, sometimes you do end up with a very edematous foot and you sort of debride. And as Tabby said, you know, you sort of may need to come back another day after 24, 48 hours. So I guess there's a lot of competing issues as to how best to manage some of the foot wounds that you see, or the abscesses that you see. I guess I'm not sure that's a perfect answer, but yeah, that's kind of how I see it. Is that what you're thinking, Matt? Or
yeah, I'm just trying to, yeah, I suppose I'm just trying to get some discussion. I mean, like I say, when I went and spent some time with Rooney, you know, there's obviously a lot of aggressive debridements and amputations, likely because of, you know, just the late presentations and stuff. Mm. And Rooney, with regards to, and I don't think I saw microbiology, but do you have micro available at the National Referral Hospital?
Yes, we do generally. We do have microbiology. I think what has not really, you know, caught on with our team is, you know, getting a debridement specimen to the lab. Mm. A lot of people just depend on the, you know, sort of the issue of password, but I think it's been emphasized that, you know, getting a debridement specimen is probably more useful. And I think it's interesting what Tabby talked about, you know, getting a sterile bone specimen to the lab, as you know, it will guide you on your, how long you treat the patient with antibiotics. So that's something that I learned as well tonight. But I also like to thank Abby for an excellent, very detailed talk.
That's good. I suppose I have one question though, and I think then we'll probably wrap up. But what sort of access to anti-infectives do you have, Rooney, in terms of your antibiotic choices? Are they quite limited with what you're faced with?
Yeah, but I think for us generally, like for most of the admissions, we put them on cloxacillin and metronidazole and in the renal functions, okay, gentamicin. We tend to reserve ceftriaxone if the renal really have severe sepsis. But yeah, basically that's basically what we.
Is there much in terms of multi-drug resistance that you know of, or is that just you don't have those sort of knowledge in terms of the patterns or the types of pathogens you commonly get in these infections?
Yeah, I think I don't have any latest information on specific for diabetic food, but occasionally we do have multi-drug resistant antibiotics. I think it's not that common.
Interesting. Okay, well, look, again, I suppose in light of the time, I think we'll probably wrap up now. I just really appreciate everyone joining us this evening. Rob, Fitridge for joining us, and particularly Tabby for working with me to put in most of the presentation. I just think it was a really common sense and not too out there with regards to, the equipment and stuff. And so she's done a really good job at trying to bring it down to potentially, what you'll have access to. And again, to Gary for inviting us and giving us a chance to have a chat about diabetic feet in the Solomons. And hopefully, fingers crossed, myself and Tabby and Rob can gang up and actually manage to get out there at some point, because it'd be fantastic. I know Tabby's itching to come out. So.
Well, thank you very much. Excellent talk. Enjoyed it immensely. I wanted to hear a bit more from Rob, but maybe next time. So I just want to highlight the future Zoom sessions page on the DAISI website. So yeah, look, apologies again for the mix-up over tonight's date. We had some people logging in last week for this session. So the DAISI surgical Zoom sessions are the last Tuesday of each month, and the next one will be Tuesday the 27th of July. It'll be Professor Charbel Sandrusi, Daniel Cosman and Mike Bowen. Hopefully Mike can stick it out, because his Zoom reception is not so great at Giza Hospital. And there's also a uterine conditions talk before then, if you've got a gynae bent, and an anaesthetic session as well on the 18th of July, the difficult airways. So thank you everyone for your attendance, and that's it. We'll wrap up now.
Thank you. Bye, everyone.
Bye.
Thank you.
No,